Welcome to our joint pain webinar series. My name is Sarah Hibner, and on behalf of Premier Health and Premier Health Orthopedic Specialists, I'd like to thank each of you for attending this evening. We're so glad to have you with us. Tonight, we're here to discuss joint pain. As you may know, joint pain is a common issue for many. You are not alone. The good news is there are options to help you reduce your pain, increase mobility, and get you back to the activities you love. Our physician expert, Dr. Matthew Lawless, will give a brief presentation this evening on those options. He will also answer some of your questions during and following his presentation. To submit a question, click the Q&A button at the bottom of your screen and type in your question. You may send in your question at any time. There may also be a chat button on your screen, but please disregard that and just send your questions by clicking the Q&A button. We'll try to get to as many of them as possible tonight. Also, the seminar will be recorded, so you will receive a link to the recording via email in the next few days, likely early next week, should you want to go back and reference any portion of this evening's presentation. So let's start off the evening by introducing our speaker. Matthew Lawless, MD, is a graduate of the University of Louisville. He completed his residency at Wright State University Boonshoff School of Medicine and a sports medicine fellowship at Methodist Sports Medicine Center in Indianapolis. He is board certified in orthopedic surgery and in sports medicine. He specializes in orthopedic and sports medicine issues related to the knee, including ACL surgery, meniscus and cartilage pathology, adult reconstruction, total and partial knee construction, total and partial knee replacements, and revision surgery. Dr. Lawless practices at Premier Orthopedics, one of the largest and highly trained orthopedic sports medicine and orthopedic practices in Southwest Ohio. The practice offers the full range of treatment options from exercise and physical therapy to injections, pain management, and surgery where needed, including minimally invasive, orthoscopic, and robotic arm knee procedures. With nearly 30 doctors and more than 12 locations, Premier Orthopedics is ready where and when you need their help. Thank you, Dr. Lawless, for being with us this evening. I will turn the presentation over to you.
Thanks, Sarah. Hey, as Sarah said, my name's Matt Lawless. I've been an orthopedic surgeon for about 20 years. I specialize in knee surgery and knee problems. That's essentially what my practice is entailing. Today, we're going to talk about knee arthritis. Please feel free to send your questions in at any time, even early on, any expectations or things you're looking to learn as we go through this. So in case I don't touch on it, the earlier we know about it, so we have time to get to it all. So we're going to talk about knee osteoarthritis. That's the common form of arthritis. That's what we're primarily going to focus on tonight. So we're going to start by talking about what a normal knee looks like. So this is a model of a normal knee. All the muscles are removed. And what we're looking at here is the kneecap. And this is where the muscles come down to straighten your knee or extend your knee. And this is the kneecap. This is the femur. This bone below is your tibia. And these things in here are your meniscuses, and then your ACL and PCL. You can tell on the side, there's a collateral ligament on each side of your knee. This is what a normal healthy knee looks like with the ligaments, the meniscus, and this stuff on the end of the bones, which is cartilage. So this would be a pretty normal looking, I'm going to jump through some slides here, pretty normal looking knee with no damage to the cartilage. So what arthritis is, and there's a picture of what this would look like. Also of note is the knee is surrounded in a capsule. The capsule contains the knee, and it's called the synovium. The synovium, sometimes when there's issues inside of the knee, will secrete a fluid called synovial fluid, and that's what causes a lot of swelling in the knee, is the synovium and the tissue surrounding it. There's a picture of what essentially this looks like with the anatomy pointed out. This is what an x-ray of a normal knee would look like. You can tell by looking at the x-ray there that black space in between, so essentially what you're looking at is the femur on the top, The patella you can see overlying the femur there in the middle of the femur, and below you see the tibia. You also see the fibula off to the side. So a normal knee x-ray has that black space in between, and what that black space is where the cartilage is. X-rays pick up bone, so they see the bone, but they don't see the cartilage. So that's why that black space is there, is because that is the cartilage in your normal healthy knee, and that looks like a pretty healthy knee x-ray. So what osteoarthritis or knee arthritis is the wearing away of the cartilage at the ends of the bone. This is usually a genetic predisposition, meaning that if you have it, probably someone in your family had it at some point, your parents, grandparents, someone along the genetic tree gave you the gene for knee arthritis, and it starts wearing away of the cartilage at the ends of the bones. It can happen on the femur, can happen on the tibia, can also happen on your kneecap. Oftentimes people, especially younger people, they start noticing crunching in their knee. What that crunching is also called crepitus. It's from wear and tear on the cartilage on the backside of your kneecap usually. So when your knee is going like this, instead of being nice and smooth, like in this model, as it starts wearing out, you hear that crunching and grinding and clicking in your knee. And that can happen with arthritis as you start getting that crunching grind. It can happen in your kneecap, but it can also happen on the inside or outside of your knee. This is the inside of your knee. You can tell it's the inside because the little bone is on the outside. This is the medial side. This is the lateral side. A lot of times arthritis seems to affect the inside in the kneecap first. So people end up with a deformity more like this as this cartilage wears out. So essentially what cartilage is the wearing away of the ends of the bones, the tibia, femur, and kneecap, and the cartilage starts going away. So you can see in this picture here, the picture on the right shows what happens when the cartilage starts going away. You can see on the inside of that knee that the space has gotten a lot closer. You also see spurs starting to form. So when you start getting arthritis, when this cartilage starts wearing away, you start getting spurs, osteophytes on the edge or lip of your bones that cause little bumps that you can feel on your knee sometimes. This is what an x-ray of an arthritic knee looks like. So once the wear and tear has started taking place, you can see there the x-ray on the right side of the screen is a pretty normal looking x-ray. You can see the space in between the femur and the tibia. On the x-ray next to it, you can see how it is no more space in between, especially the inside where it's bone on bone. And you can even see where the bone on the femur right here is starting to wear differently into the here. You can see how this shape of this tibia here is different than this shape because of the wear and tear. You can also see some spur formation here, spur here, and you can even see probably broke off a piece of those spurs right here, and that might cause a loose piece in your knee. So what happens when people start getting this wear and tear of their knee? Well, their knee usually starts getting stiff. The stiffness is most likely because you don't have this smooth gliding anymore. Now all of a sudden it's not as smooth, so you get some bumps, you get some fibrillation or crepitus as we talked about, and we also get swelling. So as the cartilage starts wearing out, it doesn't always wear out in nice smooth little pieces. It can sometimes have little chunks, and these chunks of cartilage that sometimes fall off can cause swelling in your knee. The swelling in your knee can be related to changes in activity. So say you're not used to hiking. You go for a few mile hike one day up and down hills, jumping over creeks. That might be enough to make your knee start swelling because it's something out of the ordinary. Once you start getting this wear and tear of the cartilage, knees don't like changes. So if you're used to walking and then all of a sudden you start jogging, your knee may respond by starting to swell a little bit and start feeling a little bit stiff. The crepitus we talked about is the lack of the smooth surface. The smooth surface starts going away. So you start having the crepitus or grinding or catching in your knee. Some people feel that they start getting weak or their knee starts buckling. I hear people complain about that a lot. The buckling is usually not due to any ligament injuries. The ligaments are usually fine with arthritis. What happens with the buckling is two things. First of all, as we get older, we have a tendency to get weaker anyways. And secondly, when your knee starts hurting and getting stiff, a lot of people start avoiding using it. So it slowly gets weaker and weaker. As your knee gets weaker, then when you try to do normal activities, sometimes it will buckle on you, mostly because your quads and hips are starting to get a little bit weak. I say quads, that's the muscle on the top of your knee here that straightens your knee out. So obviously if your quads start getting weak when you step, your knee may buckle like that. And what it actually is doing is it's just your muscles are a little fatigued and it feels like it's giving way. A lot of people, when they start getting knee arthritis, also feel differences in barometric pressure. So when a cold front moves in, when a rainy front moves in, a snowy front, something like that happens, they may notice that their symptoms of swelling, stiffness, and soreness happen to get a little bit worse. All these symptoms together can lead to limping. So people hurt to straighten their knee, bend their knee as they get stiffer, so they walk with a limp. And we'll talk about that later as part of the treatment. So what do you do when your knee starts getting arthritic and you start having symptoms? The first thing I have people start with, as far as medicines go, is Tylenol. Tylenol is a pretty darn safe drug to take. You can take up to 3 grams a day. A typical dose of extra strength Tylenol is 500 milligrams. So you can take 6 of those a day, and that stays under your 3 grams a day. So you can take 6 Tylenols throughout the day. If the Tylenol is not enough to keep the symptoms at bay, then I use something, there's something called Voltaren gel. This is what I show my patients, that it's just a tube like this that has a gel in it, and the gel is an anti-inflammatory. So you rub that on your knee, and that seems to be a good way to get anti-inflammatories or NSAIDs to your knee. And it doesn't seem to have as many systemic side effects as the oral NSAIDs. So oral NSAIDs, like listed there, ibuprofen, Aleve, Motrin, those things are oral anti-inflammatories. The Voltaren gel is actually a cream you can rub on, and all those things are over the counter. If you do take the pills, Aleve and ibuprofen seem to work well. You can even take the Tylenol with an anti-inflammatory. So if the knee's very flared up, I tell people to take the Voltaren gel with a couple Tylenols 2 or 3 times a day, and that seems to work well. So I'm a big believer in physical therapy. Everybody that comes sees me gets physical therapy of some sort, whether they go to a formal therapist or whether they do it on their own. As we talked about, when you start getting arthritis, you start getting stiffness, you start getting weakness, you start limping. Reversing those things usually helps make a knee feel a lot better. So the first goal of mine when someone presents with knee arthritis is to get their motion back, because they usually start getting stiff. If it hurts to straighten your knee all the way, you stop straightening your knee all the way, and so it has a tendency to start getting stiffer. It doesn't want to straighten. I highly encourage people to fight through that a little bit and force themselves to start straightening their knee and bending their knee. This doesn't cause any damage. It may be a little bit sore, but working on stretching it usually makes a knee start feeling better. So once you start working on straightening and bending, the next thing to start working on is the quad control. So the quad, as we talked about, is a muscle on top of your knee. That's what quad control, and I talked about the buckling that sometimes happens, that's the quad muscle not working to keep your leg as straight as it should. So I have people work on quad control, doing stuff like leg lifts, and straightening their leg out all the way, straightening their leg when they stand up, those type things to regain their quad control. After they've worked on motion and regaining their quad control, the next thing I work on is strength and teaching them how to walk normally. A lot of times people with a limp, I will give a cane to offload some of the soreness in their knee and some of the pressure on their knee. And a lot of times you can correct someone's gait, i.e. the way they're walking, to more normal by having them use a cane or sometimes a crutch or sometimes even a walker. But the goal is to try to get people to walk normally. I don't like to see people limping. Limping causes back pain, hip pain, other knee pain. So I try to get people to walk as normal as possible by reestablishing their motion, getting their quads to work again, and then teaching them how to walk with either the goal is to get them independently walking, so get them off, but a lot of times a walker or cane is a way to get them there. There's no downside to physical therapy. There's nothing in a knee that can be made worse by physical therapy. So I highly encourage people to go to a therapist. And my goal of the physical therapy is to teach people exercises to do at home. So once they go to a therapist, they go for a few weeks, but the goal is they are supposed to be doing the exercises they learn in physical therapy forever. So people ask me commonly about bracing. So we talked a little bit already about what a varus knee is, and you can see on that middle picture a varus knee, and you can see that the inside of the knees have worn out, and so it falls into a varus deformity, and that's very common with osteoarthritis to get this varus deformity. Sometimes people get what we call a knock-kneed or valgus deformity, which is the picture on the right, but most times it's this varus deformity. So they make braces that act to counteract this. This is one that would be used for a valgus knee. You can tell that the outside of the knee is over here. So what it's doing is trying to push the outside over like this. So I'm sorry, this is for a varus knee. So the person was like this, and they're trying to use the brace to push the knee back center like that. These braces do work well sometimes in people with skinny legs. They don't work well in people with bigger legs. And because they do push pretty hard on your knee, they're not very tolerable. So they work for a few hours, but then they get uncomfortable. So people's compliance with using these, what we call offloader braces, is pretty low. These braces are usually pretty expensive, several hundred to $1,000 or more dollars, and they're not usually tolerated. They can work in an active skinny leg, but most times I try to direct people just to a regular knee sleeve like this, just something that pulls up over their knee, and that seems to provide some relief. They're usually inexpensive, they're usually well tolerated, and you can use them anytime. I stress to people that if they do use a knee sleeve, they still have to keep working on their exercises because it doesn't substitute for doing the physical therapy and doing the hard work of rehabbing their knee. So the next level, once therapy and the medications aren't working as well, the next thing we talk about is injections. There's multiple kinds of injections to be used in a knee. The most common one is cortisone or steroids. What happens with that is we take the knee and essentially I put a needle right into the knee, right into this space under the kneecap, and inject steroids into it. We usually inject a little bit of numbing medicine with it because the steroids have a tendency to burn a little bit, but the numbing stuff takes that away. So we put the steroids in, and steroids work well in the knee injection, especially in mild to moderate arthritis. So in people with earlier arthritis, steroid injections seem to work well. The steroid injections are usually pretty inexpensive. They're usually pretty effective. How long they last, however, is kind of variable. As the arthritis gets worse, they seem to act for a shorter period of time. and everybody responds differently, and everyone responds differently to every injection. So the time of length varies. Hopefully you can get months of relief from it with someone with mild to moderate arthritis. And you can do cortisone injections. Usually the insurance companies pays for it about every 3 months. So you can come in every 3 months if they're working effectively and get a cortisone shot. Once the cortisone shots become less effective, then the next kind of injection is hyaluronic acid. Probably the most popular one of these is called Synvisc. Synvisc is, so hyaluronic acid is a product of, so I talked about the synovium that surrounds the knee, and sometimes with arthritis, it secretes a fluid, synovial fluid. This hyaluronic acid is one of the parts of the synovial fluid that they create in a lab. So they take a lab and they make this thick hyaluronic acid, which is essentially a thick lubricating fluid. And that's just like a cortisone shot where we inject it right into the knee. And it kind of acts as a lubricant and keeps the knee moving. People with mild to moderate arthritis on the average get about 6 months of relief, some more, some less. There's many, many types of hyaluronic acid. Synvisc is probably the most common and most popular one because it's been out the longest, but there's other brands that make it too. Oddly enough, usually the brand I use, I try to use Synvisc, but the brand I use is oftentimes dependent on the insurance company and what the insurance will pay for and what type of hyaluronic acid we use. The insurance companies usually pay for it for 6 months. Sometimes I will even do a cortisone injection a few months after a hyaluronic acid injection, and that seems to work well too, especially if the time isn't right to do surgery or something else to address the knee pain. Other things that people commonly ask me about. So as I said, hyaluronic acid, the insurance companies will pay for it every 6 months. So if you're getting at least 6 or more months of relief from it, it's reasonable to consider just repeating that, and as long as you're comfortable and able to do what you want to do. There's a couple newer things that people are doing for injections. PRP is one. PRP is essentially where you take your blood out, you spin it around, and then you take the plasma part of it. So as you spin it around, the blood separates out. So you have the blood and then the plasma at the top. You take the plasma off. The PRP stands for platelet-rich plasma, and you inject the plasma or the PRP into your knee as you would the cortisone or the hyaluronic acid. And that seems to work pretty well. Insurance companies don't pay for it, so I don't use it. One of my partners uses it. It's an out-of-pocket expense. The studies with the PRP seem to show that it works as effectively, at least as hyaluronic acid. And in some studies, it even works a little bit better than hyaluronic acid. So in my practice, excuse me, in my practice, I use PRP when it becomes an out-of-pocket expense. If the insurance companies aren't paying for the injections anymore and they still want to keep going with injections, PRP is a bit cheaper than hyaluronic acid. So the people will pay out of pocket and get a PRP injection. The other type of injection is stem cells, and there's a lot of variation of where the stem cells come from. It can either be from the patient or it can be from a donor. Stem cell injections have been much less studied. They are also out-of-pocket expense. The insurance companies don't pay for stem cells, nor, as I said, pay for PRP. The stem cells are usually several $1,000s. And again, there's no real studies supporting the use of them. So I shy people away from spending their money on the stem cells because it is such a big out-of-pocket expense that really doesn't have much in the way of science supporting its use, at least not yet. So what happens when all these kinds of treatment options don't work anymore? We don't have anything that can be reliably put the cartilage back on the ends of the bone. We don't even have anything that reliably slows down the progression of arthritis. All the treatment things we've talked about, the therapy, the anti-inflammatories, Tylenol, the various injections, none of them have been shown to slow down the progress of arthritis. How fast arthritis progresses is highly dependent on the person. Sometimes it starts slow and takes a long, many years to progress. Other times it's more aggressive, starts more aggressively and goes through its course more aggressively. And that's probably more genetically driven than anything, but so far we don't have anything that stops or slows the progression of arthritis. So then we talk about doing surgery. And the surgery for arthritis is what's listed there as total joint arthroplasty. That means total joint replacement. Total joint replacement has been a very effective surgery. It is a surgery that we do a lot of. I do 200 to 300 of these surgeries a year because they are so darn effective. Total hips, total knees are probably considered the two most effective surgeries in medicine. What we do with a total knee is essentially, since the tips of the bones are worn off, we trim off the tips of the bone and replace them with metal and plastic. So what it looks like is this. So you can see that the side ligaments are kept in place, but we've trimmed off the tip. So you can see there, we trim off the tips of the bone here on the femur, and we put something that looks very similar to the end of a normal femur back on like that. And we do the same thing on the tibia or the shin bone. We put a metal, we cut flat, we put a metal piece here, and we put a metal piece that has, obviously if you have a knee replacement, your knee doesn't do this, but has a little keel to it like this. And that keel is placed in there, and this plastic piece fits on here. This is polyethylene that is in there. And then instead of the bone rubbing on the bone, because that's what happens with the arthritis, as the cartilage wears off, it exposes the bone underneath. So instead of the bone on bone, you have the metal on the plastic, and that gets rid of people's symptoms. But you can see it's called a joint replacement, but it's actually, we're just taking a little bit of bone and then worn out cartilage off the tips of the bone. So it's more of a joint resurfacing than a joint replacement. So we can do a partial knee replacement where this metal and plastic is only on the inside. I said that most of the arthritis usually comes on the inside of the knee. And when that happens, when it's isolated to the inside of the knee, you can do a partial knee replacement where this metal and plastic is only on one side, or you can do a total knee, which is what this is an example of. And here's what it looks like for a partial knee. You can see how the metal, so metal on x-ray is white. And so you can see the metal, or the white part on the femur, the white part on the tibia, and the space in between is the plastic. Again, plastic doesn't show up on the x-ray, as does cartilage, but you can see how on the x-ray on the left, there's bone on bone arthritis here, and it's been replaced with this resurfacing of the femur and the tibia with this plastic. The advantage of a partial knee when you're a candidate like this, and not everyone's a candidate, most people are not candidates, but for ones that are candidates, it's a little less invasive of a surgery. You can see we're just doing a part of the knee instead of the whole thing. And they usually are just as effective as a total knee. And it's a shorter rehab because it's not quite as invasive surgery. So this is what a total knee replacement looks like. And you can see again on the x-ray, or yeah, the x-ray on the left, where you have the bone-on-bone arthritis, you have the spurs, you even see a little cyst here. A lot of times you'll get some cyst formation with osteoarthritis, but that's what that knee replacement looks like on an x-ray. So that's an x-ray of something like this with the knee replacement. Again, the white part on the x-ray is the metal, and the black part in the middle is the white part is the plastic. And that's a side view of it right there. You can see the metal and the plastic with the kneecap on front. So with the knee replacement, this one doesn't have a kneecap, but with a knee replacement, we also take the underside of this, we saw it off, or we resurface it, meaning we make a flat surface out of it, and then put a piece of plastic similar to the one here on the kneecap. So how I usually do a knee replacement is if someone is ready for it, if their x-rays show that they have end-stage arthritis, if they're bone on bone, if the injections, the Tylenol, the anti-inflammatories are no longer working, if they've had therapy and that's no longer working, then we talk about doing knee replacement. Knee replacement is a surgery that takes about an hour, hour and a half to do. We often do it as an outpatient or an overnight stay. I usually use a spinal anesthetic. So people arrive at the hospital, they get an IV started, and they get a spinal anesthetic. Then we do the surgery. They go to the recovery room and then to the floor. After the spinal anesthetic is worn off, they have physical therapy. As the physical therapy, if they do well enough, then they can go home that day. If they need an overnight stay, then they stay overnight. After they go home from the hospital, the first couple of weeks, I keep them at home. The reason I keep them at home is after doing a knee replacement, there's a lot of swelling involved in the knee. We try to minimize the swelling in the knee. So what we do is we use ice and we try to keep the knee elevated above the heart. We have them do some very simple exercises, getting their motion back, getting their quad control back. We usually have them do that 4 times a day, and otherwise they're keeping it elevated. If they do get up and walk, I ask that they just walk short distances, 5, maybe 10 minutes at most if they're up, and then back laying flat with their leg elevated to keep the swelling down. We use anti-inflammatories, we use Tylenol, we use aspirin post-operatively. So one of the risks of knee replacement surgery is blood clots. The way to prevent blood clots is to do the exercises, to do a lot of toe and ankle wiggling. And I also usually use aspirin. Sometimes I use a little other stuff like Coumadin or Lovenox or Xarelto, but usually we use aspirin to help prevent the risk of blood clots. So they'll take the aspirin as well. We often send people home on a narcotic, but we try to limit that. One of the ways we limit that is the anesthesiologist who did the spinal anesthetic will do an injection just above the knee where the nerves that come down to the knee run, so they can put an injection in here and make this not hurt as much by knocking out the nerves in the area. And that seems to work well also. Another thing they get are antibiotics. The things I worry about most when doing a knee replacement is infection. So we make sure they get a dose of antibiotics before and after surgery, and then blood clots. So we make sure people do their exercises, make sure they wiggle their toes, and also take their aspirin. So that is that. After the 2 weeks of therapy at home, then I send them to an outpatient therapy. Oftentimes, patient has already been to a therapist when they met me at some point along their treatment course, and we usually use the same therapist. That's what we discussed. Everyone starts with a walker after knee replacement. So a common question is, when will I be back doing things I want to do? Well, most people start with a walker. They get off a walker when they're able to. When they're able to kind of depends on how they are beforehand. So the people that are stronger and walk more aggressively before surgery seem to get back quicker. So they get off a walker sooner. People get off a walker anywhere from 2 to 5 or 6 weeks after surgery, again, depending on what their prehab or pre-therapy state was. They get back walking normally and doing things they want to, usually by about 6 to 8 weeks. I see people in my office at 2 weeks after surgery. We'll make sure their motion's okay, make sure everything looks okay. And that's the time they go outpatient therapy. They're still a little bit sore most times and usually on a walker. They're starting to feel better. I then see them back at 2 months, so 6 weeks after that. And by then they're almost always off the walker, feeling much better and very glad they had the surgery. Probably the most common thing I hear afterwards is, I wish I would have done this sooner. I've had a lot of questions lately about a robotic surgery. So when we do a total knee replacement, we use instrumentation called the traditional way of doing it. We use different landmarks on your knee, and we use different instruments to line up where we're going to make our cuts, and it's all very well designed. A robot is supposed to help the outlier. So I do use a robot in complicated cases where there might be hardware from a previous fracture. If someone had a femur fracture or tibia fracture, then that is a time when I'll use the robot. There's a lot of misconceptions about robots as far as quicker rehab, quicker return to function. I don't necessarily see that, and most of the literature doesn't support that, but it does help in some cases when there is a difficult deformity or something out of the ordinary, and that's when I usually use the robot. The outcomes with knee replacements are very good. That's why we do so doggone many of them, is because people do so well with them, and they do help people get back to their lives. So Sarah, that's all I have. If there's questions.
Yeah, we do have quite a few questions, so thank you so much. As a reminder, if you would like to ask a question, please type it into the Q&A, which you can find by hovering your cursor over the bottom of your Zoom window. So we will get the Q&A started here. So first question is, what are the pros and cons of robotic knee surgery?
So kind of what I was alluding to there, the pros are you don't have to use the standard instrumentation. What you're looking to do is to get a more reproducible surgery. So that's why I use it for some of the more complicated cases where the traditional way just won't work. The downside is a lot of times, especially early on, it takes a little bit longer to do a robotic surgery. You have to put pins. So to do the replacement, the robot has to know where the knee is and all the landmarks. So to do that, we have to put 2 pins in the tibia here. So you get a couple extra incisions there that people notice afterwards. But that's really the only real downside.
Another robotic surgery question. Where are robotic surgeries done? Are they done at Miami Valley Hospital, and which doctors do them?
So almost everybody so I work mostly at Miami Valley South, and at Miami Valley South, the surgeons, almost all the surgeons do use robotic surgery to some extent or the other.
Okay, great. Another question, do any of the concepts you talked about today apply to hip joint pain?
So as a knee surgeon, I don't have as much experience with hip replacement, with hip arthritis. The therapy is a little bit different with hips. Therapy can be beneficial for hips. Hip replacement surgery is actually probably even easier to rehab than knee replacement surgery. Hips usually feel better after surgery than knees, and they rehab and get back to their function much quicker.
Okay, our next question is, will hyaluronic acid taken orally work as well as injections?
Great question. It doesn't seem to work as well. Vets are very high on using hyaluronic acid as a pill, but there doesn't seem to be any downside to using it. Glucosamine and chondroitin sulfate are products of synovial fluid, and that's the common one that people take, the glucosamine and chondroitin sulfate. Most studies show that it doesn't really have that much effect for pain relief, and it doesn't seem to put cartilage back on the end. So like I said before, we don't have a disease modifying medicine for arthritis. There doesn't seem to be a downside, so it's no harm in trying it, but and you may get some pain relief. So
Okay, next question. I've been using the gel only once a day, no Tylenol. I still have knee pain. Would more gel treatments per day help with Tylenol?
probably you can use the gel 3 or even 4 times a day. So if you're not getting enough relief with the gel once a day, I would probably do gel and Tylenol a couple times a day and see if that doesn't make a difference.
How do you feel about acupuncture?
Um, Great question. We don't have much science supporting the use of acupuncture. I don't think there's a downside to it. If you know someone that's willing to do it and you can afford it, then there's probably no downside to it. There's not much in the scientific community to support it helping with knee soreness, but I've certainly had patients try it and like it. So I wouldn't discourage it if you can afford it.
Okay, the next question is, can I still get down on my hands and knees after total replacement?
Great question. Kneeling after a knee replacement can be done because we make the incision right on the front of the knee. So we make the incision for a knee replacement right down the front. It usually is a little tender afterwards because when you go to kneel on it, obviously you're kneeling right on your incision. But people can teach their knee to be able to kneel again. So I usually have people like practice kneeling on a pillow that's on top of a bed and slowly get more firmer surfaces. And so after a week or two of doing that, then people can kneel. Some people can kneel right out of the gate, but if they can't, then you can get your knee accustomed to it by doing that.
Okay, we have a couple questions around how long a knee replacement will last. So the first one is, how long does a total knee replacement last? If I have it done at age 60, will I likely need to have the replacement replaced at some point? And then what is the typical operating life of a knee replacement?
So when we talk about knee replacements, we talk about their survival rate. Once you put them in, how long are they going to stay in the person? So the 10-year survival rate, so what percentage of total knee replacements are there at 10-year mark is usually about 90 to 95%. So at least 90 to 95% of the people, if you had a total knee replacement today, would still have that same total knee in at 10 years. At 20 years, it's probably about 75%. So it does start to taper between the 10 and 20 year mark. That is with the old kind of plastic. So this plastic in here is about 5 years ago, we started using a different kind of plastic that has vitamin E in it. And for some reason, that seems to make it last a bit longer. But we've only been using it for about 5 or 10 years, so we don't have as much survival data on it. But in the bench, so when you cycle this like this on a machine, it seems to last a lot longer. So hopefully the survival rates will even be better than 75% at 20 years once we've figured that out.
All right, should you have both knees replaced at the same time?
Great question. I do bilateral or both knee replacements at the same time. My criteria is the person has to ask for it. It's nothing I'm going to push on them. So they have to ask for it. They have to have a negative cardiac history, meaning they can't have any history of AFib. They can't have any history of heart attack or coronary artery disease. And they also cannot be a diabetic, and they have to have a BMI of under 35. A BMI is a body mass index, height, weight thing. So they have to be on the relatively skinny side as well.
Okay. We have just one question left. So if you are interested in asking a question, feel free to go ahead and type it in the Q&A box. So the next and last question that we have at this point is, who is a good candidate for robotic joint replacement?
Again, I would do a robotic knee replacement on somebody that has had a previous injury to their knee, like a femur fracture, like a tibial plateau fracture. So if they have any hardware, metal from a previous fracture around their femur or around their tibia here, those are the people that I would do a robotic surgery on. Sometimes people with big deformities, meaning if their knee is really crooked one way or the other, then those might be good candidates as well.
Okay, we did have one more question. And again, continue to feel free to ask questions. We still have plenty of time left. So when do you decide if if a partial or a total is needed?
So looking at your x-rays is usually the biggest determinant. If the x-rays show arthritis in only one of the three compartments, so by the three compartments, I mean, there's a medial compartment on the inside of your knee, there's a lateral compartment on the outside of your knee, and there's the patellofemoral compartment. So you can see all these different compartments, these three compartments on x-ray. If the arthritis is isolated to one of the three compartments, whatever compartment it may be, then those are the people that I would discuss a partial knee replacement. If you have disease in more than one of the compartments, then that is when I would do a total. Most people that we see already have arthritis in more than one compartment and usually end up with total knee replacements.
Okay, we have a question about volatin. So could volatin be effective for relieving hip pain? Oral NSAIDs are not effective for me any longer.
Once the oral NSAIDs stop working, there's no real downside to trying the Voltaren gel on your hip. There's no downside to it, but it starts making me think that once the oral anti-inflammatories aren't working as well, that it's probably getting towards the time of discussing surgery.
Would a Baker's cyst require a knee replacement?
So a Baker's cyst is a cyst that forms in the back of the knee. So as we talked about, having arthritis causes your knee to form fluid. That fluid can leak in the back of your knee and form a Baker's cyst. So the pain generator is usually the arthritis and not the Baker's cyst. So I usually, if someone has a Baker's cyst in isolation that's painful, it usually means something else is going on. The only time I do a knee replacement is for knee arthritis, and I certainly wouldn't do it just for an isolated Baker's cyst.
Okay. You mentioned vitamin E being used in newer prosthetic joints. Are there any new materials coming in the near future that will alter the procedure and rehab? And then if so, when do you anticipate that common usage?
I'm not aware of anything. I have not read anything, nor have I talked to anybody that's working on anything in the knee replacement that will do any of those things.
Okay, is this issue typically hereditary?
Yes, so most people have a hereditary link to the arthritis. Sometimes the arthritis might be from like an ACL tear, where you tear your ACL and do some cartilage damage at the same time. So you can get a post-traumatic arthritis, but most osteoarthritis is hereditary or genetic.
Do you do most of your knee replacements at Miami Valley Hospital?
I do most of mine at Miami Valley South, almost entirely. The advantage, I guess, to expand on that, the advantage is we have a very good team. The people here know what to expect. We do a lot of them. Like I said, I do 200 or 300 a year. There's other surgeons that also do high volumes here. So the staff, the nursing staff, the anesthesia staff, the OR staff, everyone knows what we expect, and it is a very well-oiled machine that works very well.
Okay, I can bend my knees about 120 degrees. After surgery, will I be able to bend them more through physical therapy?
If you're bending them 120 preoperatively, you should be able to get that afterwards. Will you get more than that? It kind of depends on how the therapy goes and how your body habitus is. But I would expect to get around 120 afterwards. Can you push it and get more? Yes. I have patients with 140, 145 degrees of flexion.
Okay, if I have an old meniscus tear and that's causing discomfort, is physical therapy recommended?
So with a meniscus tear, the first thing I do is get physical therapy on board. There's no downside to physical therapy. You're not going to hurt the meniscus tear. You're not going to make it worse. So I try to encourage people to ignore their meniscus tear, work on strengthening. So a lot of times therapy will make a meniscus tear not hurt. And of course, if you ever got to a point where you're fully rehabbed and you still have soreness, then you would talk about an arthroscopy.
Okay. Next question. I had knee surgery 45 years ago on my left knee, and 20K volts exit my right knee 32 years ago. Can I get both done at the same time?
So if your BMI is under 35, if you want them both done at the same time, if you don't have any heart history or any risk factors from your heart and you're not a diabetic, then getting them both done at once would be reasonable.
Okay. I think that was the last question. Okay. All right. Well, thank you so much, Dr. Lawless, for your informative presentation. We appreciate your time and expertise. And I want to thank you so much for joining us this evening. I hope that you found this information shared useful. We feel privileged to be with you tonight and hope that you consider us for any healthcare needs you may have. If you'd like to learn more about Dr. Lawless or his practice, Premier Orthopedics, you can visit premierorthooh.com. More information about Dr. Lawless can also be found on his bio that was sent along with the information to access tonight's event. Should you have additional questions or would like to make an appointment, his office phone number is on both the practice website and on his bio. Last but not least, as a reminder, the seminar was recorded. We will email you a link to the recording should you want to go back and listen to some or all of this great content again. As soon as it's available, we will share the URL to access the recording. Along with the recording URL, we will share a link to a short survey on tonight's program. We value your feedback and would appreciate if you could take a few minutes to share your thoughts with us. And with that, we wish you all a great evening. Thanks again.